We're now live, yes.
Thank you. Okay, good morning, everyone. I'd like to begin by welcoming those members of the public and press who are watching the live stream of this meeting via the Council's website. Members of the subcommittee, you are by now aware of the need to keep your video camera switched on for the duration of the meeting and to keep your microphone muted except when I invite you to speak. Please click the raised hand function if you wish to ask a question or comment. There's always a risk that we may run into technical problems, and I would ask for your patience if we do. Should this occur, I will declare an adjournment while the fault is addressed and the public broadcast will be paused. If it's not possible to address the fault, the meeting may be abandoned until such time as it can be reconvened. Can I remind the subcommittee and officers and public speakers, if there are any, that all virtual meetings will be recorded and that these recordings will be published on the Council's website. Okay, so members, I'll begin by calling the names of all members of the subcommittee to establish your attendance. Please confirm your presence by saying yes or present. Councillor John Holditch? No.
Yes, sir. I am here.
Dr. Gary Howson? Obviously not. Louis Camphor?
Present.
Thank you. Louise Mitchell? No. Val Moore?
Hello, yes, I'm here.
Hi. Wendy Oger-Welborn?
Present.
Liz Robin?
Present.
Jan Thomas, I know isn't, and myself, Councillor Roger Hitford. Okay, agenda item 1, notification of the chairman, chairwoman. As set out in the subcommittee's terms of reference, the chair alternates annually between Cambridgeshire and Peterborough, except for the first appointment, where the appointed chair will remain until the end of 2021 municipal year. On that basis, I will remain as chair for the current municipal year. Yay. Agenda item 2, election of the vice chairman, vice chairwoman. The vice chairman woman cannot represent Cambridgeshire or Peterborough councils. Do I have any nominations, please?
I'll nominate Jan Thomas.
Thank you, Louis, and I'll certainly second that. Is anyone any other nominations, please? Therefore, I duly say that Jan Thomas is the vice chairwoman for going forward. Thank you very much. Agenda item 3, changes in membership. I need to report one change in membership. Louise Mitchell has replaced Jess Baldwin as one of the CCG representatives on the subcommittee. Agenda item 4, apologies for absence and declarations of interest. We have received apologies from Charlotte Black, the Service Director, Adults and Safeguarding. Are there any other apologies, please, Rishinda or Nick, from when I was reading out? Or have we received any others?
No other apologies received, Chair.
Okay, thank you. Are there any declarations of interest at all, please? Right, can't see any. Okay, thank you. Moving on, agenda item 5, minutes of the 7th of November 2019 and action log. We should have all had these in our emails, etc., for this meeting. So can I confirm the minutes as a correct record? Would anyone actually disagree with that? I'm seeing no hands at all, so I'll take that as correct and read. Okay, moving on to the action log. There are 3 outstanding actions. I was going to ask Jan if she could provide an update on the first action on page 7. Is anyone else able to do that at all? No, we'll have to leave.
Sorry, apologies. Would you mind just reading it out? I don't think I've got a copy of the papers. Apologies.
I haven't got the minute. I'm just reading from the chairman's notes at the moment. Liz, have you got the minutes in front of you, please?
I do. So, Louis, it says the CCG accountable officer reported that she would provide the exact figures reflecting the growth in non-elective admissions at Addenbrooke and Peterborough City Hospital to the clerk to circulate to the subcommittee. And that is quite an old action. I think that predates COVID. So that was when there was a great deal of concern about the growth in non-elective admissions.
Okay. I'm happy to take that away. Apologies for not doing that sooner.
Well, that's fine, Louis, if you could please. As Liz says, it's quite an old action, pre-COVID. So if we can just bring closure to that in some way, that would be appreciated. Thank you. Okay, Liz and Wendy, can you update on the 2 actions relating to the Best Start in Life strategy on page 8?
Happy to update, Chair, on that. So pre-COVID, we were about to launch the pilots on Best Start in Life, but obviously that has been put on hold. But I'm pleased to say that we are now looking to launch actually in 5 areas. The pilot of the Best Start in Life, and associated with that will be a communications plan. And I'm very happy to share that at the next meeting, because we will have that information then. And the second part of the action was around making it clear that the work around fostering adoption was separate to Best Start in Life, which we have done, Chair. Thank you.
Thank you very much. Thank you, Wendy, for that. Anything else from anyone regarding the action log at all? I'm seeing nothing. Okay, I shall move on. Agenda item 6, Integrated Commissioning Board Priorities Updates. So we've got Val and Caroline. Are you presenting this? Which one's going first, please?
Yeah, I'll just start off, if I may. I'm very pleased that Caroline's here, who leads, you know, all the practical work and much of the strategic work on commissioning for the 2 authorities. The paper reflects what the Integrated Commissioning Board has been doing and thinking and proposing to you since May, but really this is a second half of the story, really, because this core group hasn't met since November, and that seems a long time ago, and an extremely valuable amount of work was done through the board between January and March. We were all due to present that and prepared papers for you, but obviously the March meeting was cancelled because of the crisis at that point. So that there's, just to briefly say something about the pre-March bit before we focus on where we are now. We had prepared a set of commissioning principles which would support the system going forward in the future, and gained a lot of agreement and buy-in for that. We'd listed all the jointly commissioning services and all the separately commissioned services between Peterborough, Cambridgeshire, or jointly in the County Council, and all the CCG commissioned services that were relevant to the joint agenda. And we had created a schemata of those going much further than the coming year, but right through till the renewal of, for example, in 23-24, the Healthy Child Programme. So we're looking at opportunities for joint commissioning to be improved through the natural cycle of commissioning and through the priorities of the system. We'd also look to review the performance of the Better Care Fund projects and agree metrics and do the preparation for reporting on that last year, which you'll notice from the appendix of the current paper has come 6 months late. We're now required to report on that. So that kind of explains that bit of the paper. So on hold since COVID, we met in May to consider the relevance of the immediate period to us, and I'll ask Caroline to take you through the paper as to where we've got there. But I see the commissioning board as bringing some transparency of information, quality assuring information amongst the members, agreeing what to disseminate and how, understanding how that dissemination occurs in each organisation, and really undertaking deep dive workshops on areas of common interest to build that knowledge of the learning and the opportunities in commissioning coming forward. So that's a bit of the style that we've adopted over the summer. And although the attendance has been relatively small, they've been very productive meetings. And I'm hoping that this core group can help connect that with Louis, for example, and Wendy, in terms of the high level understanding of where this is going commissioning. So that was by way of a historical sort of introduction. And regret we can't show you all the good work we did to March, but it is there to be revived in the autumn, because we think it's still valuable to work in that manner, as well as what we've been doing since May. So on that level, I'll hand over to Caroline, who has been excellent support and leadership with me on this.
Okay, thank you. Caroline.
Thank you, Val, thank you, Roger. So just building on what Val said, obviously we've been meeting again as the Integrated Commissioning Board since May. And it seems like a really opportune time as we're coming out of the immediate response to COVID, and obviously system priorities very much being focused on that, to actually take an opportunity to reflect on the impact that COVID had in the joint commissioning landscape, and the role of the Integrated Commissioning Board going forward, and how it could best support that strategy and approach for joint commissioning as we move forward into sort of the next phases, and what new normal will start to look like. I think just really kind of recognising within the paper that we did recognise that COVID has had a significant impact on the landscape. And although that has obviously been very challenging, there have been some real positives that we can draw out of that. So actually, in terms of the joint commissioning landscape, we had to respond very rapidly to the COVID pandemic, and that led to a number of joint commissioned opportunities to ensure that we had the right capacity in place. And there was an awful lot of developments, particularly around discharge to assess and hospital discharge pathways, which meant that joint commissioning and joint working to support those had to happen really, really rapidly. So what we wanted to really focus on is how we could continue to build on the progress that we'd made and really take that forward. So in terms of priorities for the Integrated Commissioning Board going forward, as Val indicated, we've been very keen to start to understand some of the business intelligence and modelling and sharing of information of what we are seeing happen currently. And we've had a number of deep dive sessions. The initial was very much to look at the COVID impact and start to work up our priorities, but we've also done some quite specific sessions, particularly looking at technology enabled care and how we can continue to build on some of the digital resilience steps that have happened during COVID, and very much looking at how we can develop more links with primary care. And there was a real opportunity we identified to strengthen that work, particularly with some of the work that's happening in the South Alliance to progress forward with the integrated neighbourhoods work. And we had a really good update in terms of how that is being picked back up again, because an element of that had also been paused during COVID, and we'll be focusing more on that within one of the future meetings once they've redetermined their priorities. I think we also had identified some real opportunities to build on the support for homelessness, because an awful lot has happened in that sphere during COVID, and we had a really good session looking at opportunities for how we can ensure that we've got the right wraparound support for homelessness housing related services going forward. In terms of one of the other big areas that has been identified around joint commissioning for review is learning disabilities. So there's a lot of work happening currently to look at the learning disabilities day opportunities. We recognise that that's been an area that's been particularly hit by COVID and is in need of an awful lot of focused work, and looking at opportunities, how that can be delivered differently going forward. And we have I think our next meeting is actually, we've got a focus session on that, so that will be kind of high up on the list as well, as we're having a look at some of the digital access review information that has been led by the voluntary sector, to see how we can kind of continue to build on the digital resilience work and look at joint commissioning opportunities on top of that. So I think some really good initial priorities have been identified. Feels like we are able to sort of get some pace now, and the Integrating Commissioning Board has a clear role within that recovery and resilience work going forward. I think the other area that I really just wanted to touch on briefly was the Better Care Fund. As Val indicated and as outlined in the paper, all of the Better Care Fund reporting was suspended at the beginning of this financial year. Well, actually at the end of last financial year. So Q4 reporting for last financial year was suspended and was just literally resumed at the beginning of September. So we have attached the Q4 report so that you can see the final year end position for the Better Care Fund for last year. I think it's probably fair to say that the Better Care Fund has very much been focused on existing provision being maintained during this period. We obviously did pause the evaluation work that we were undertaking, but that has been identified as a priority to pick back up, and we will be looking at that in more detail at the October Integrated Commissioning Board in terms of initial findings. We recognise that there isn't any national guidance for this financial year at the moment, and currently we don't have any indications of when that will land with us, but we still feel that it's important as a system to be on the front foot in terms of reviewing and planning for into the remainder of this year and next financial year. I think that's probably the key elements. So I think me and Val are probably happy to take questions.
Thanks, Caroline. I haven't got anyone immediately raising their hand, but could I ask, just on a point you raised, you said that we needed to make sure we had the right wraparound support for the homeless. Could you just elaborate on that and what we've actually done so far?
Oh, yes, I can. So we've so during COVID, there was a huge focus on ensuring that homeless were placed in suitable accommodation so that they were removed off the street. So there was a huge piece of work around that, and also in terms of housing related support, there was additional capacity that was also commissioned to make sure that any issues around isolation were also able to sort of be adhered to, so that we could move people into that provision if it was required. I think it's fair to say there's been an awful lot of work with the districts and link up, particularly around the community hubs and the support that the community hubs has been able to put into there. Where we were particularly keen is to make sure that we continue to build on that in terms of transition plans for those people as they as we move forward into the next phases, and how we can make sure that we've got the right wraparound, we've got the right GP provision in place, we've got health provision, we've got a range of services around those individuals as needed. So I think that's an area very much that our commissioners and the CCG are working jointly on, very closely with communities. We were quite, although it's in very early stages and it's not confirmed yet, but we are in discussions with the Better Care Fund national team about the potential of support and maybe potentially some funding to do some work with homeless to support hospital discharge as well, which I think would be a really good opportunity if it comes off too, but we're waiting for some more news on that. Val, did you have anything additional to add, I think, that came out of the session?
I can recall that Sue was very keen to get the board's input to her presentation because she was taking the proposals for new ways of working to the Housing Board and to the, so and we haven't had the feedback about how those decisions have progressed yet, but I got the sense that in coming to the board, she'd valued that extra perspective and buy-in from people there. And in fact, various CCG people, Alex McCann, took it on board to make some specific links and representation at the board so that it was joined up, whereas membership of the Housing Board, for example, didn't necessarily involve some of the people that it should, given the conversations we had about the opportunities for improving the commissioning. And there was another piece she spoke about, was a solution for young people, which needed more thinking, but that was an area where they wanted to develop, particularly as well as the hospital discharge issues, where people are then propelled back into a chaotic situation, whereas something could be done there. So that's my recollection of the value of that discussion and where it's got to at this point.
Okay, thank you. I mean, for me, it's just we have such an opportunity here. We've almost, I'm not going to say been forced into it, but circumstances have given us the opportunity that it's just how we go forward with this, because obviously there's a lot of good work that's been done, as you say, across partnerships and community hubs, etc. It'd just be good to try and keep an eye on how we take this forward. I've got a couple of people that want to come in. I've got Wendy and then Liz. Wendy.
Thank you, Chair. So just really relating to what you've just said, Roger, is through the Think Communities approach is where we are harnessing really the energy and enthusiasm from our local communities in terms of supporting the areas of greatest need. We know that in terms of the homeless, many of our staff were redeployed to actually provide interventions to the homeless, as well as many of our community services. And through the Think Communities approach, and we've been talking a lot about that, and we'll be very happy to bring some more information here about it, is we do want to harness that capacity and take it forward, not just for the challenges we faced in COVID, but the challenges that we know our communities face anyway. So I think it's really given us the impetus to do that. Alongside the things Caroline's talked about, we've also developed across the local authorities and health a recovery and resilience plan, and that includes how we want to integrate the work of Think Communities alongside the adult and health services. And I think it might be helpful for this board to consider us bringing that plan to the next meeting, so that actually publicly people can see the work that we are doing together, building on all of the good work during the pandemic. Thank you.
Great, thank you, Wendy. Thank you for that. Liz?
Yes, I have two questions. I think that the first one is maybe for Louis, and it is about some of the work that's been happening in Peterborough in terms of health service support to rough sleepers and that agenda. There's been some fantastic work that's been done, particularly by one of the local GP practices, but it has been done very much out of goodwill. And I think there is a real opportunity there for the NHS commissioning arrangements to embed some of that work into mainstream business, which will be needed going forward, because we see the difference that it's made. So it's just a question for Louis as CCG representative. I think is probably the right person to ask about whether that thinking's going on.
Shall we do that first? You said you had a couple of questions, so
yeah,
we'll do that one first. Louis, is there a response there?
So it is very much, and yes, the thinking is going on, Liz. I think we are, as others have said on the call, I think there's a lot of examples that we are thinking about how we embed that in kind of mainstream business as we move forward. A lot of really good work that's happened and a lot of partnership working that's happened. But in terms of that specific example, I'm happy to talk to you about that offline and get a bit more detail so that I can feedback at the next meeting, or Jan can.
Okay.
Fantastic. Thank you. Thank you.
Liz, you had another question.
I do, yes, and I'm not, the other one may be for Louis or Caroline or others. I was very pleased to see the emphasis on infection control in community services going forward. That was very clearly stated in the paper, and the reasons are obvious. But I'm aware of some of the issues in the hospitals that the infection control requirements have created, with perhaps fewer people being able to, fewer beds on wards, distancing, all those things. And I was wondering what practical impact that was having on the community services, and whether there were specific issues there that were impacting on capacity.
I'll take that one.
So I mean, shall I start, and then Caroline, if you want? So I think the infection prevention. So Liz, is your question? Can you just repeat the question? It's the question about the impact that infection prevention and control is having on community capacity.
Yes, that's right. Does it mean that you need more people to do the same amount of work because of the various constraints? So there are impacts that will have an effect during the winter.
So, I mean, the infection prevention and control guidance is having an impact everywhere, isn't it, across the health services, because we need to put different things in place going forward. And one of the key things that we're focusing on our recovery work is the extent to which we can recover services very quickly and rapidly, but also the extent to which we would need to still adhere to the infection prevention and control guidance and put those additional things in place. So there's a lot of work happening in that space at the moment, but it is having quite a significant impact. I would say that depending on the type of service, it's having probably more of an impact on our acute services. It's probably more of an impact on our bed-based services, but it is having an impact everywhere. So quite significant and quite a big piece of work that's happening, as you know, at the moment across our system in terms of recovery.
Okay, thank you, Lou.
Can I just jump in for an additional bit on that as well? So, you know, very much agree with Louis that that is having a huge impact and having a huge impact on sort of community providers. It's probably quite a timely question because we're going into the care home support plan report of the next item on the agenda, which very much talks around our approach towards infection prevention control within care homes, but we recognise obviously that it's much wider, and I think in terms of capacity, some of the areas where we're seeing a real impact is around sort of that workforce capacity. So we very much recognise that the additional requirements to embed infection prevention control around minimising sort of workforce movement between providers, etc., is creating certainly a additional reliance on additional staffing or agency staffing for providers and for community provision, which is certainly having a significant financial impact for our community providers. There has been significant sort of financial input into the independent provider sector through the infection control fund, to get the terminology right, infection control fund, which came nationally. I mean, we've also been supporting providers on a number of other levels, but I think it's really important to recognise that financial input nationally actually comes to an end at the end of September, and certainly infection prevention control measures are now very much an embedded way of life for providers going forward. So those financial and workforce and capacity impacts won't be going away for our community provision.
Mm. Okay, thank you.
Is that all right, Liz?
Yeah, that's helpful.
Great, thank you both for those responses. Okay, I've got no more hands raised, so we're asked to note and comment on that report, and I think we've done that, so thank you very much.
I think,
Roger, you're on mute.
Am I? Did anyone hear anything I said then? That is so unlike me.
Not a word.
I never get caught out like that. Well, I'm not saying it again. You just have to guess. No, I said we're moving. We haven't got any more on that, any more raised hands. So we'll move on to the next agenda item, which is agenda item 7, better care homes. The care home support, which is Caroline again, as she mentioned. So thank you.
Thank you, Roger. Thank you for repeating yourself. So just to give you, there's quite a bit of information in the report, but just to give you a high-level overview of the contents. Nationally in May, all local systems were required to develop local care home support plans and submit them at the end of May. And this is very much focused on infection prevention control within care home settings. We're talking about residential and nursing home, and that was in line with the requirements nationally in terms of what our plan needed to cover. This happened alongside around the same time that we were also notified of National Infection Control Fund allocations as well. So the focus very much of the local plans was to explain our approach locally around how we would embed the infection prevention control principles with our local providers, and how that would support the aims of the infection control funding as well, to ensure that those outcomes were being delivered and we could minimise outbreaks within those settings as much as possible. I think it's probably fair to say that there were a number of key areas that are covered within the plan, which were at a high level were the recommendations around what infection prevention control needed to cover from a national perspective and from national best practice. So the plan is focused around 5 key areas of support, because we recognise that actually infection prevention control is it's wide ranging in terms of the support that's needed with providers, and it covers a number of facets to enable providers to be able to operate and embed those practices in a fundamental way to their working practice. So the plan looks at how we will ensure that we support providers around infection prevention control skills and knowledge, how we use our local surveillance data to understand what's happening in terms of local outbreaks, and what our coordinated response needs to be, and ensuring that providers have that capacity to be able to isolate residents and staff as and when they need to. There's a focus in the plan around access to testing to ensure that there is suitable testing in place, both for new admissions to care homes, so sort of building on Liz's comment, for anyone who's being discharged from hospital, for instance, into a care home, so that we are aware of people's testing status before they are admitted into care homes and the appropriate measures can be put in place. But also rapid testing for and regular testing for staff within those settings and residents within those settings to reduce the risks of asymptomatic transmission. There's obviously a very strong thread around making sure that providers are supported with access to PPE and to equipment supply, and that's both locally being able to ensure that they've had access to things in the immediate emergency responses, and they can come to us if there are difficulties with them accessing, and supporting them in terms of supply chains around where they can access appropriate equipment, and making sure that they have the skills and knowledge to use that as well. But we also need to recognise that a large part of the infection control funding was very much around sort of workforce support, so how we can actually strengthen the workforce resilience to minimise workforce movement, and also how we can ensure that there's the appropriate clinical wraparound, multidisciplinary team wraparound support to care homes, so that they can support residents as best as possible within those settings. The full plan is published online on the website, and the link is in the report. So if you haven't seen it already, obviously you can see that online if you're interested in reading the whole report. To back that up, what we have done is developed an action plan for locally, just in terms of ensuring that we're really clear around the local actions that are required and the progress on those. And that plan is overseen by multidisciplinary out of hospital cell, which has system-wide representation on that. There's quite a bit of information in here, but I suppose I probably just wanted to note kind of a couple of key things, that there is a very strong sort of governance system in place around review and monitoring of what we're seeing locally. So a local intelligence cell was established at the onset of the pandemic, which looks at the data on a regular basis, and that feeds into our local care home cell, which is a multidisciplinary cell which very much reviews that data and looks at information and feedback that we're getting back from providers in the system in terms of what we're seeing, and reviewing what areas of support may need to go in, both across the board or to individual providers, to help them manage particular instances. For fear of probably rambling on for a very long time, I think it's probably best to assume that you've read a lot of the detail in there, and probably open up to questions, because I'm conscious there's a lot of information behind this, and I'm happy to take sort of specific questions on any areas that people want clarity on.
Thanks, Caroline. I haven't got anyone immediately, but I'll start off again, because it's something that I keep meaning to ask, and you've just prompted me to ask it again. So with testing, obviously I know it can take 2 to 14 days for people to show symptoms, if they're going to show symptoms, etc. But with testing, and obviously you can go and get tested once you start showing the symptoms, but if we're testing people that haven't got any symptoms and probably haven't got COVID-19, how soon is it that if they have got it, it shows up in a test? Because the reason I'm asking is, if we're testing people that are coming out of hospital, going into care homes, have we got the timing right on that? I.e., if someone's caught COVID-19, does it show up within an hour of testing, or what's the time frame on this? Sorry, I hope I've made myself clear.
Yeah, no, the question's perfectly clear. And I'm not sure that I'm necessarily the best person to answer. Liz, is that something that you have clarity on, or is it something that we need to sort of get back and respond on?
I think I can give the general overview, and it's a really good question, and it's something that's often not understood easily. So COVID-19 incubates in the body, and you'll pick it up on a test when it's actually there in the nose or the throat. That's when you can pick it up in a swab test. But when you first catch it, it can be incubating elsewhere. So you can be infected with COVID-19, but that doesn't show up on a swab test. And I think there is quite often a misunderstanding. People think I've been in contact with someone with COVID. They're told they need to isolate themselves for 14 days, because it can take up to 14 days for the symptoms to show. And they think, oh, I'll just go and get a test. And then, maybe I wouldn't, I'd get out of it. And that's not the case. You can have a case on day 2, a test on day 5, a test on day 7, and they can all be negative, but you can still develop the disease on day 9. So you have to isolate for that 14 days if you have been in close contact with someone with COVID, because you can develop these symptoms at any point, and often a test won't pick it up. So that's a really good point, Roger, that it's the isolation that's important, and actually a test doesn't help with that. The care homes are slightly different, because they're testing people every week, and it's a setting with potentially higher rates. We know that care home staff are more likely to have COVID than the general population, or that's been the case in the past. So that's more worthwhile, because you're checking them very regularly, and you will pick up some asymptomatic cases.
Yeah, I understand, and thank you for that response. But that does lead me to say, yes, we're trying to put a ring fence around care homes, and we're testing people coming out of hospital. Actually, to get it absolutely right, we need people to be in hospital 14 days after they were going to be discharged, to see if anything's going to happen, and that's never going to happen. So we can do the best we can, obviously. But nothing's ever perfect on this one, obviously.
Yeah.
Absolutely, and Caroline can answer that one, I think.
No, I absolutely agree as well, Roger. And I think it's around like with all of this, it's around sort of minimising the risk as much as possible, and that's very much where, as Liz indicated, the isolation practices, and there are isolation practices within care homes as part of infection prevention control that we are working with providers for them to make sure that they are embedding. So there will be where they're able to look at being able to kind of isolate off, or to have particular staff working with people who are known to be have COVID infection or at risk of COVID infection, etc. So there's a bit of a sort of cohorting practice that happens within homes to be able to kind of actually do some of that isolation. That's, you know, I think it's probably fair to say though that that's quite difficult for some of the smaller providers who may not have the capacity and the space to do that. So that is an ongoing challenge that we work with, and I think we're constantly reviewing the situation locally to make sure that we have got appropriate provision where people can be isolated where they need to be. So that is an ongoing conversation locally, definitely.
Yeah, great. Thank you for those responses. I've got Val and then Wendy. Val?
Thank you. I've just got a quick point which may or may not be a question to be answered, but it's about PPE equipment in care homes and in health sector settings. The government's announced that it's supplying the masks with the visible mouth area to support people hard of hearing and deaf in terms of being able to lip read and be assisted in that conversation. And you know, with my hat on that sort of champions the individual and their specific needs, it's something that Health Watch have been sort of advocating as that these masks are available for people to get and buy, but for healthcare or care home professionals to be wearing them would be a great step in sort of reducing that isolation and difficulty in communication that results from. So it's I don't know where we are with that in using them in our care homes. They're certainly they're approved, but they're being piloted in terms of their implementation in hospitals currently. I know that. But I wondered where we are with that, and if it's something that we can promote as a good practice point going forward and try and support that supply to our care homes.
Yeah, it's a good point. Caroline, do you want to just quickly comment on that?
So I'd agree, Val. I think that's definitely something that we can support the messaging with care homes and promoting access to that. I couldn't answer definitively now how widely that is being utilised within those settings at the moment. What I can say is that in terms of PPE, we are working with providers, very much independent providers are responsible for sourcing their own PPE, but we provide support in emergency provision, which they can access both nationally, and also they can come to us locally if they're having any issues accessing PPE. But to support them to make sure that they know where they can, you know, where are reliable suppliers, who the type of suppliers who have stock, or, you know, who are charging sort of reasonable rates, etc. So we do continually update them with information around how they can access PPE in the best way. And I think as part of that we can absolutely do some promotion around those masks, and that's something I'll take away and I will discuss with our contacts team so that we can pick that up.
Thank you very much.
Thank you. Wendy?
Thank you, Roger. I just wanted to go back to the issue of the testing and the 14 days of requirement to self-isolate. That is very much captured within our recovery and resilience plan, and looking at what capacity that we've got across Cambridgeshire and Peterborough to ensure that people are able to self-isolate for that 14 days, be that within a care home or other environment. So I think you will see that within the report that we hopefully can bring next time, and our action plan. So we are working as a system to make sure that there is that capacity. Thank you.
That's really good news, Wendy. Thank you for that. Thank you. I've got no one else that wishes to speak. So again, we're asked to note and comment. So thank you very much on that. I'll move on to the next agenda.
Thank you.
Roger, you're on mute again.
It's a far better meeting when he's on mute, isn't it?
I was pressing my button to mute myself. How bad was that? Okay, so agenda item 8 is the forward agenda plan Rishenda.
There are no changes to the published plan, apart from obviously the report that Wendy suggested that comes to the next meeting.
Great, thank you very much. Anyone else on the forward agenda plan at all? Seeing nothing. Okay, so thank you everyone. Productive meeting, some good information there. And I thank you for getting up for a 9 o'clock meeting. I didn't realise there was 2 9 o'clocks in the day, so thank you. All right, I declare this meeting closed.